We're now going to begin the first lecture in the very last offering of this course, Audiological Rehabilitation and Auditory Processing Disorders. So as most of you know, you will be the last students to take this last sequence of courses. And for some of you, this will probably be the last course in your AUD program. I'm going to be teaching the APD portion of this course. As you can see here, I have faculty positions around the world. My two primary faculty positions are as a permanent part-time professor at Salus University. I think you all probably know where that is, just outside of Philadelphia. And then I have the pleasure of also being a permanent part-time faculty member at the University of Hawaii. How that came about is an interesting story, but the chair of the department is one of my audiology brothers, in that his mentor was also James Jerger. And through some conversations that we had at meetings, I realized that he had developed an undergraduate online program for mostly teachers and others who were interested in going into speech pathology. So they had an undergraduate degree. Some have actually degrees in nursing, other linguistics, various degrees, psychology. And they decide they want to be a speech pathologist, and they have to take some prerequisite courses to get into a master's program in speech pathology. But of course, that program also includes a course that's going to introduce them to audiology, and a few courses like speech and anatomy and physiology of the speech and hearing mechanism, etc. And I have a master's degree in speech pathology, which I got at Northwestern University. So I felt comfortable teaching a few of the other courses. So that's why I'm affiliated with Hawaii, and I go there once a year. I'll be going there just before this course gets started. In 2019. And some of my other faculty positions are here. Of course, I have an email address. You all know it because it's on the syllabus. You're welcome to contact me anytime privately or post questions on the course website. I also have a recently updated and revised website, audiologyworld.net, and I encourage you to go there to find whatever you were interested in and download it and take it away. I had the good fortune of completing my early audiology training after I got the degree in speech pathology, the master's degree at Northwestern, with Dr. Jerger in Houston, Texas. And I converted from speech pathology to audiology at that time, back in the early 1970s. The whole story is on my website if you want to read all the details. Anyway, so from the very beginning of my audiology career, literally the moment I set foot in an audiology clinic, I started seeing patients who had auditory processing problems. Now, back then we didn't call them that. The term APD was actually coined probably in the early 1980s. So back in the 70s, we just referred to them as having central auditory problems or central auditory nervous system dysfunction. And Dr. Jerger was, in the United States, the #1 person for validating our behavioral tests to make sure that they really are evaluating central auditory functioning, and they're not evaluating only cognitive function or some other non-auditory issue. And so therefore, I'm very comfortable going into a clinic and evaluating a patient to determine whether or not their brain is processing auditory information correctly. This is a photograph of me. The photograph's a little worn, but I'm over on the right-hand side looking at the photograph. Hair was a little bit longer. Obviously, I was quite a bit younger. And Larry Malden was just a wonderful guy who helped out in the clinic, then went on for his PhD in audiology as well. So I'm not going to bore you with the list of publications, but I do want to make sure that I get the point across that I'm not just lecturing from a textbook. I'm not just reading a book chapter on APD and then turning around and explaining it all to you. This is in my audiology blood, and it has been for 40 years. Every clinic I've ever been in, most of the time I'm directing clinics or chairing the department, I've immediately set up established services for children and adults who might have auditory processing disorder. And so that knowledge over the years And the research results that I've produced over the years is what's kind of the foundation for this course. So I know what I'm saying is true because I've done it many, many times. And I know that these are underserved patient populations. That is, children and adults with auditory processing disorders are rarely adequately identified, diagnosed, or managed. And you can be helping people in a way that almost no one else can help them if you just see these patients. So here's some of my papers. Actually, my very first article that I published in 1976 had to do with APD, and a second one too, the one where I studied central auditory function and stuttering. I was still a speech pathology. I was still working a little bit in speech pathology at that point, and then I switched over to audiology. So these are some of the central auditory or APD papers I published back in the early 80s. And then I started evaluating patients with severe head injury. I started working with surgeons, first at the University of Pennsylvania, then at the University of Texas in Houston, where now I'm seeing patients coming in with very severe head injuries. Some of them died, of course, but some of them did survive. And so I knew that this population was at great risk for APD, and we started evaluating them and showing that almost no one who had a severe head injury would escape without some degree of auditory processing disorders. We also studied it when I was at Vanderbilt in patients with dementia, including Alzheimer's disease. And you'll learn in this course that there's a direct connection between auditory processing and dementia. In fact, one of the very first signs of dementia is a deficit in auditory processing. Now, of course, the results of our tests of auditory processing can be affected by cognitive function. So there's that listener variable. We'll talk more about listener variables, but it makes sense. If the brain is impaired enough to produce dementia, it's likely that the brain will also have a hard time with the very challenging, sophisticated auditory processing that is necessary for normal communication. And then I've written some book chapters along with Frank Music and some articles with Frank Music and Gail Shermack, two big names in APD. And you'll be reading a few of these publications in this course as required readings. And then more recently, we've been looking at other aspects of patients with APD, and not just auditory aspects, including psychosocial status. So at the end of this course, you will be very, very aware that children with APD and adults with APD often end up with psychosocial consequences. They really feel badly about themselves, and they're frustrated, and we'll go through the whole list of them. And that's been published as well, and you'll be reading that last article. And finally, don't want to bore you with these publications, but we've really found that you can help patients with APD. This is one reason I like to work with them. You can help them, and you can help them quickly. In fact, to be honest with you, the benefits of management for APD are much quicker and usually more extensive than the benefits of management of peripheral hearing loss. And a reason for that we'll get to later, but bottom line is there's neuroplasticity, brain plasticity. So when a person has a cochlear hearing loss, there's nothing you can do about the cochlear loss. All you're trying to do is to give them amplification to help them hear soft sounds that they're not hearing, perhaps using some technology to help them hear a little bit better in background noise. But essentially, you're dealing with a cochlea that can't be changed. So they're never going to have normal hearing function. Whereas with the brain, very often the cases that we're seeing, the patients we're seeing, the brain can be changed. It's capable of tremendous change. That's the whole neuroplasticity or brain plasticity concept. So you can after management sometimes not even find any problem with auditory functioning, whereas there was a major problem before. And so that's all summarized in some of the more recent articles, and we'll emphasize that a lot in this course. That concept that we can change the brain and we can therefore essentially remediate auditory processing disorders in many patients. I mean, that's really at the crux of why we try to manage these patients. Pardon me, I just took a sip of water. That last article is Another required reading for this course. It's about 10 years old, but it's still totally valid and it adequately explains our general approach to APD. And I wrote that with Terry Bellis. Okay, so very quickly, and I don't want to spend much time on the history. There's an interesting history on APD, and if anybody comes up to you and says, "Well, isn't that kind of new stuff, this APD, and we don't know much about it," and I heard there's really no way to evaluate patients with APD, or some people don't even think it exists, and certainly can't do anything for these patients. I immediately say, well, wait a minute, what do you think is new? I mean, because the first papers describing assessment of auditory processing go back to the mid 50s, 1950s. I mean, that's, 60 plus years old. So there's a long, long history of people trying to evaluate APD and trying to manage these patients. Now, I will admit that up until the 1990s, there were a lot of gaps in our knowledge. There weren't many good tests to diagnose APD. There weren't many good strategies, at least very specific strategies for managing patients, and there wasn't a lot of evidence in support of the good outcomes for management. But that's all changed since the 1990s. And there are literally thousands of articles on this topic. We'll get to that in a little bit. The history of APD has steadily been progressing. I mean, we learn more and more each and every year. And although we have some fundamental questions still to answer, at this point it is clearly we know enough about APD to identify it, to assess it, and to manage it effectively. So the mid 1950s, I mean, that is a long time ago. Most of you think that's ancient history. I was around in the 1950s, but I was not interested in audiology. I was, just a child. But one of the first articles, and it's a classic, and I'd be happy to have you send a copy to you if you're interested, was published in 1954. And these were Italian otolaryngologists. They weren't even audiologists. In Italy, there aren't any audiologists the way we think of them. They're always physicians, mostly otolaryngologists, and a lot of them just don't do surgery. They focus more on audiology as their specialty. And this group of otolaryngologists had normal hearing patients, normal audiogram patients coming in, and they were complaining about problems understanding speech, problems hearing in background noise, and they were very clever. They said, well, there must be something wrong with these patients, even though their audiogram's normal. And we now know, of course, you can have a lot wrong with your auditory system and still have a normal audiogram. So what these otolaryngologists did is they filtered speech. They removed some of the high frequencies from speech, and they found that when you had these garbled, mumbled words that were filtered, normal people with normal brains and normal ears had no problem recognizing the words. Whereas some of these patients that were complaining of hearing problems couldn't understand the words at all. They scored very poorly on this filtered word test, and they started finding that these patients had temporal lobe tumors. They had surgery for the tumors. Some of them died. They had autopsies. And so this was the first test showing that you could actually evaluate central auditory functioning in a patient clinically. Well, people like Dr. Jerger and others latched onto this and said, wow, this is a whole group of patients that we should be evaluating. Again, I'd be more than happy to send you this article. It's truly a classic. Now, at the same time, ironically, the same year, 1954, a psychologist, Helmer Michaelbust, who was at Northwestern University, he began to also realize, wait a minute, a lot of these patients that we see have normal audiograms, but they really do have auditory problems. And some of them are kind of like auditory learning problems. Now, Michael Buss is a fascinating guy. He lived well into his 90s, originally from South Dakota, but he ended up at Northwestern University and basically founded the discipline of learning disabilities when he was there. When I was at Northwestern University in the early 70s, I would see him all the time in the hallways, and one of his students was one of my just best professors and when I took a course in learning disabilities. And Jim Jerger was also a student there many, many years earlier, back in the early 50s. And he has wonderful stories in his books. I sometime in the course I'll have to upload covers of the book so you can see what they look like and you might want to buy them. But he tells stories about how the first time he went into one of Michael Buss' clinics. Now, again, Michael Buss was not an audiologist, he was a psychologist. Um, he found that all the patients had normal audiograms, and he said to Helmer Michael Buss, wait a minute, I think I'm in the wrong clinic. I'm an audiology student. These patients have normal audiograms. I need to go to another clinic, I guess. And he says, no, you don't. You're in the right clinic. Um, these people with normal audiograms have all kinds of auditory complaints, and it's our goal, our job basically, to find out what's going on with these patients. Why can't they hear even though their audiogram's normal? So I have this book right behind me in my study here in my home in St. Augustine, Auditory Disorders in Children, and it talks all about the central auditory system and how audiologists need to go beyond the ear when they evaluate patients. Well, around the same time, mid 1950s, several people started to explore ways of evaluating neurological function through hearing. And one of them was, well, these are all psychologists except for Jack Katz. And basically, I won't get into all the details. I could give you access to a book chapter that I've written where I've reviewed the history. But dichotic listening tests were developed during this time frame, and they were really not being developed initially to evaluate patients. They were being developed to study auditory memory from a psychological point of view. But people soon began to realize, particularly Doreen Commurer, a psychologist in Canada, that these tests really picked up patients who had central auditory problems, even though they weren't designed to do that. And Jack Katz said, well, yeah, they do. And he designed the staggered spondaic word dichotic test specifically to evaluate central auditory function in children and adults. So Donald Broadbent on the left, he was an extremely well-known British psychologist, famous. He developed the dichotic listening paradigm. Doreen Commurer, who's still alive, by the way, she was a psychologist in Canada, and she was working in a neurological institute in Montreal, and she found that these tests, dichotic tests, were very, very sensitive to anything going on in the central auditory nervous system. Well, then two audiologists, roughly the same age. Now, I guess, let's see, they'd probably be in their mid 70s, mid to late mid 70s, I'd say. Jack Katz and Robert Keith, both semi-retired audiologists. Some of them never retire. I guess I'm in that category. And so they're both functioning and in the profession, working. Bob Keith was just at the American Academy of Audiology convention in Columbus, Ohio, 2019 convention, and he actually had some students presenting on APD. So they both made huge contributions. Jack Katz mostly in the area of dichotic testing with the SSW, and Bob Keith has developed all kinds of APD tests, written on it extensively, and we'll summarize some more of his communications or contributions very shortly. Well, I mentioned the 1990s earlier as being kind of where APD really took off, and that was because of all the research going on in neuroscience during that time. This is called the decade of the brain. And so all the neuroscience research, the development of functional MRI scans, which is basically like a video of brain activity, whereas a regular MRI is kind of like a snapshot or a regular photograph of brain activity. And people began to realize that brain plasticity was a real phenomenon and it could be utilized in therapies. People began to focus on all kinds of diseases like Alzheimer's and others that had been kind of neglected. And then there was a rapid growth in technology for evaluating auditory function, both in terms of electrophysiologic measurements, but also behavioral measurements, both in animals and in adults. And then in the 1990s, we began to see the development of computer-based treatment options for APD. So, if I were to ask you, well, when did any work on APD, any attempts to evaluate patients with APD, when did that happen? You'd say, well, the mid 1950s. But when was the real explosion in knowledge, and when did APD really get on the map, so to speak, and become an accepted concept? You'd have to say the 1990s. So now, just before this class started, a couple days ago, now we're in spring of 2019. I did a Medline search. So I went to the National Library of Medicine, NLM, NIH, GOV. You know how to do this. And I just put in the three keywords, auditory processing disorders, and I come up with over 5,000 articles. Now, some of them involve really irrelevant topics. A lot of it involves animals, but a huge number of these are clinical. We could have refined the search. We could do auditory processing disorders clinical or auditory processing disorders children, and we would still get thousands of articles. So my point here is that there's a huge literature and a growing literature on APD. And I'm just scratching the surface in this course. We could have, I've taught an entire semester course for APD, 3 hours a week for 10 weeks, day after day, clinics, demos, and still we can't cover everything. It's just a very, very huge literature. So what are we going to do in this course? Well, I'm trying to introduce you to the topic, and I know that some of you are already providing APD services, and I hope that some of you will start providing them after this course. And we're going to, in a moment, I'll summarize several ways you can go about doing that. So here's direct text from the syllabus, and I strongly encourage you to read the syllabus and reread it, review it very closely. Week 1 is devoted to this overview of the central auditory nervous system, and also to a lecture on the neurobiology of APD. These are the articles I'm going to ask you to read. Most of them are quite short, 5 or 6 pages. You can read them in 5 or 10 minutes, so don't be overwhelmed by this. By far, the most important written document, the most important written source of information in this course is the AAA guidelines for the diagnosis, treatment, and management of children and adults with APD. So you're going to come back to that reference over and over again. You can easily download it from Audiology, from a AAA website, audiology.org, but it's being provided to you, of course, as a required reading. But that doesn't mean you don't want to read the other articles here. As I said, they're quick. They're very, in a sense, superficial. They're kind of summaries, but it'll get you started. Now, we have 2 videos. One of them, obviously, is what you're listening to right now, AR1, and then AR2 will be the lecture on the basically the neurobiology and neurological underpinnings of APD. What's going on in the central nervous system that results in APD? And of course, we're going to have a chat. By the time you listen to this, we may have already had the first chat on Monday nights at 9 o'clock. That's our traditional. And we have some West Coast students, so that means they can get home, or at least be done with most of their work before the chat starts. I will be moderating the first 4 chats. This course is a 7-week course. Week 4 is a transition week, so half the week is APD, half the week is audiologic rehabilitation. So Dr. Abrams will be joining me in the chat for week 4, but I'll be taking the first 3 weeks. Okay, so why do we need a course on APD? Well, obviously, APD is a hearing problem. Auditory processing, I would say, is hearing. An audiogram is not a hearing test. It's really just a measure of how well a person detects faint sounds, very simple sounds, pure tones. But to really evaluate hearing, we have to evaluate auditory processing. So auditory processing is a complex way of hearing. It's involving speech, of course, as well as non-speech signals, and very complex signals. It involves all levels of the auditory system, and it's very closely related to listening, because auditory processing really requires a lot of attention, a lot of effort, and a lot of motivation. whereas basic hearing is just automatic. You don't really need to. I mean, you could be daydreaming, you could be sleeping, and then you'll still hear something. But for auditory processing, it's a much more active form of hearing. So these are all reasons why we need a course. Now, I mean, you're going to see a lot of patients with APD. And if you say, well, I never see these patients, that means you don't realize that you're seeing those patients. It means the patients are coming into your clinic. You're just not realizing that they have APD. And you're never going to see patients, identify patients with APD if you rely entirely on the audiogram and simple word recognition. So we'll get into that more later. This is our responsibility. APD assessment and management's well within our scope of practice. Nobody else is going to do it. So it's not like, if you dispense hearing aids, some other people may dispense hearing aids, like a hearing aid dealer, or a patient may go straight to the internet and get their own hearing aid. But nobody is going to be evaluating patients with APD except an audiologist. No other scope of practice includes this clinical activity. And the other point I'll make is that if we do not evaluate patients for APD, we're really not serving our patient population adequately, because and we're not even providing standard of care, because these problems are devastating, and we have the tools, we have the technology, we have the tests to identify and diagnose APD, and we have ways of managing it. So you have to be involved in some way or other in providing services to patients with APD, or at least evaluating patients you suspect of having APD. So with that in mind, think about your clinical services. Think about, whether you see adults or children, doesn't make any difference. And I think you really have three possible options. One is the least involvement. You say, all right, I'm going to recognize risk factors for APD in children and adults. And when I see a patient has one of these risk factors, and I ask them a few additional questions, and I say, well, they definitely could have APD. I mean, they're certainly at risk. I'm not going to evaluate them. That may be in just my routine clinic. I might be seeing patients every half hour in an otolaryngology clinic, but some of them are going to have the risk factors for APD. So I'll find these patients. A lot of it can be done through a history and questionnaire. I don't even have to spend much time with them. And when I do find a patient, I'll recognize that this has to be evaluated. I can't just let this patient go away and say, oh, you've got a good ears, you've got a good audiogram, you don't have any problem. They might have a problem, so you refer them to another audiologist who does see patients, specializes, you might say, in APD. Now, my opinion is every audiologist should evaluate patients for APD, but that'll probably never happen. So here, option one is you're mainly referring patients at risk to another audiologist, or maybe you need to send them to a speech pathologist or a psychologist. Maybe you have some concerns about ADHD or language impairment, but you're referring patients after you've first identified them. So that's the minimum service that I would say you could provide. Option two is you diagnose APD. Obviously you identify they're at risk, but then you go ahead and you use an appropriate test battery. Take maybe 45 minutes of additional testing beyond the simple peripheral tests, and so you come up with a diagnosis. But then you say, well, but I'm in a clinic where I really can't perform any of the management strategies. I really can't intervene. I can't treat them in any way, but I'll refer to another audiologist for that. Or I'll refer to another professional. Maybe they need, again, a psychologist or a speech pathologist, or maybe I need to refer to an otolaryngologist or someone else. So that's option two. And that you could do in any clinic with any audiometer pretty much. You'd need a few extra tests, but we'll talk in this course about where you'd get them. So that's a very feasible option for most audiologists. Not going to take you much time. You'll be able to bill for the services. We won't get into the billing in detail, but feel free to ask me questions. I was always the biggest revenue generator in our clinic because I saw patients like these APD patients, tinnitus patients, ABRs, and I was providing complex services. I was very efficient, so I could bill out a tremendous amount of money, even though I was providing services to a population where many audiologists would say, well, I don't see those patients because I can't bill for the services. You can. So option two, very feasible. Option three is ideal. That's what I've done, and I hope some of you either are doing this or will do it. So you identify patients, you diagnose them using an appropriate test pattern, but then you also take an active role in managing the patients. Now, no audiologist is going to provide all the management for patients with APD. You're always going to rely on other professionals, but you do whatever you can do, whether it's an FM system or whether it's some type of computer-based auditory training. You will be providing that management directly, and in many patients, that's all they'll need. So please think about where you want to fit into this in these three options, and I hope some of you take option 3. I hope most of you choose option 2, and you all should be getting at least as far as option 1. Okay, well, I'm going to be covering the neurobiology of APD in another lecture, so I won't dwell on this, but keep in mind we don't hear with our ears, and this goes back to Michael Bust in the mid-1950s. We hear with our brain. And so what's the perfect proof of that? Some people would say, what's most important for hearing? Oh, your ears are. You got to have an external ear. You got to have an eardrum. That's not really important. I mean, that's good to have, but we don't need those structures to hear. In fact, we don't even need a cochlea to hear, or at least a functioning cochlea. So we know that because when we identify a child who's profoundly hearing impaired with a cochlear implant, they can communicate perfectly well. But if you don't have a brain, you've got serious problems. And if you have serious brain injury, traumatic brain injury, where there's irreparable permanent damage to the auditory regions, you will have a patient who cannot communicate, no matter how good their ears are. So we hear with our brain. Now, I mentioned the clinical practice guidelines, the AAA guidelines 2010. The cover of those guidelines is shown here in blue. And I'm just going to quickly define APD. Well, it is a hearing problem, but it involves the central auditory system very often. It's very complex, but it is an auditory problem. It's an auditory specific problem. It's not a form of attention disorder or a deficit. It's not a form of language impairment. It is a pure auditory problem. And that can be proven with evoked responses. It can be proven with fMRI. Auditory processing is the efficiency and effectiveness by which the central nervous system utilizes auditory information. That's really important. You'll have patients who they can get by with auditory processing disorders in situations where it's one-on-one conversation, there's no background noise, they're speaking to somebody who has no accent, the person they're talking to is speaking slowly, the information that's being conveyed in the conversation is relatively basic. There's a lot of contextual cues. But you throw that same person into a noisy setting where somebody's talking to them with a foreign accent, where prosody and stress is all different, or a situation where somebody's speaking very, very quickly, or the person that is listening is trying to do some other things at the same time, not just focus on hearing, like for example driving, and suddenly they can't function at all. So they're very inefficient and very ineffective in auditory processing. And very often those are the patients we see, and they slip through the cracks. They may be very bright people who memorize a lot and develop strategies, but sooner or later their auditory processing disorder catches up to them. And then the final point I'm going to make is that APD is in children and adults. It can be a result from obvious neurological damage, trauma, a tumor, aneurysm, or some neurological disease process, for example, child with seizures, or it can be developmental. And you're going to learn more about that in the article written by Gail Shermack and Frank Music on the neurobiology of APD. Will help you a lot understand these various mechanisms for APD. Okay, we're down about the last 10 slides here, so this will be about a 45-minute lecture. Recently, and this is 2016 or 2015, there's actually been the development of a ICD-10 code, a diagnosis code for APD, which is wonderful. And here's the definition: a disorder characterized by impairment of auditory processing, and it's clear that it's got to be auditory processing, not processing in general, resulting in deficiencies in the recognition and the interpretation of sounds by the brain. Okay, so central auditory processing is a brain problem. Causes include maturational delays in brain development, brain trauma, tumors, etc. It's not a language problem. So that's very important. A lot of information in this one definition. It's an auditory problem, although it may coexist with other problems such as language problems, and it involves the brain. Now, many audiologists, I know this because people have come up to me and talked to me or sent emails, they feel comfortable evaluating peripheral hearing loss, and they feel very uncomfortable evaluating patients for APD. They say, I have no problem with evaluating somebody with a sensorineural hearing loss. I just don't know what I'm doing when it comes to APD. I just don't feel comfortable. So I've put this slide together many years ago, probably 20 years ago, showing if you ask these questions of both peripheral loss and APD, the answers are almost always the same. Do you always know what's causing a peripheral loss? Rarely do we know. I mean, sometimes there's an obvious cause, maybe ototoxic drugs, but we don't usually know. But that doesn't keep us from managing that patient. We don't know exactly where the problem is. We say, oh, it's a sensorineural hearing loss. Well, that covers a lot of territory. That could be inner or outer hair cells. It could be any other structures in the cochlea, or it could be the nerve. And we don't always know where the site of dysfunction is with APD, but very often it's not irrelevant. It's not relevant. As long as we know the person doesn't have a disease or pathology in the central nervous system, where the problem is not all that critical to managing them. So it's not really a limitation. And then if you go all the way, I'm not going to go down the list, but if you go down the list of these different questions you might ask, sometimes we have the information for peripheral and sometimes we have it for APD, but often we don't. But that doesn't keep us from evaluating patients with hearing loss, and it shouldn't keep us from evaluating patients with APD. Now, this is a slide that kind of leads into a discussion that we'll have later about coexisting disorders. That's in week 2, and risk factors for APD. Auditory processing is fundamental to communication. So when you're evaluating a patient who has auditory processing disorder, they don't just have problems hearing sounds. Very often they'll have language impairment, or at least an inability to adequately use language. They'll very often have reading problems. Very often they're horrible spellers. One of the best ways you can quickly find out if a person might have APD is to ask a parent or teacher if you were giving an oral spelling test. In other words, where you were saying, spell the word cat, spell the word seat, spell the word split. You will, as you get into words where there's more complexity in terms of phonemes, the speech sounds, which are going to create more problems for the person in processing. The sounds sound very similar to them, for example. Then the spelling's going to, they're going to spell the word wrong. So people think this is a visual problem. Oh, they reverse their P's and their D's. Well, no, they're not. They're not seeing the P and the D properly, in which way the little stem goes. They're not hearing the difference between a P and a D. That's an auditory processing problem. So auditory processing deficits put the patient at risk for reading problems, communication problems in general, and you're never going to really solve their communication problem in many cases, or their reading problem, unless you deal directly with their auditory processing. So we're doing far more than just picking up people who might have a hearing loss. We're actually getting to the root cause of communication problems in many of these children and adults. Okay, now why there's nothing in this slide except this poor little student who's lost in the classroom. I do not know, but here we are. One consequence of not properly identifying and diagnosing and managing APD in children is that they're going to be going to school with inefficient and ineffective communication, and they're not going to learn. Learning, at least in the early years, the elementary years, and certainly preschool years, is almost all auditory. So that's one very serious consequence of late identification of APD in children. Another, I've already mentioned, and we'll talk more about it, is reading delay or failure. So that's one thing I want you to remember from this course, that children with APD are at great risk for reading delay or failure. And I've got research showing that the more aggressively you manage the APD, the more success they have in reading. There's a direct connection. And then kids that have problems with auditory processing that are not diagnosed, not identified, tend to do very poorly in school. Sometimes they quit school at a young age. It's a crime because the problem can be corrected, but it's not. It's not even recognized. They are at great risk, kids with APD, for specific language impairment. Specific language impairment is a language impairment with no obvious cause. They didn't have a head injury. They don't have some kind of developmental delay. It's specifically a language problem. It's kind of like the language equivalent to APD, where usually it's a neurobiological delay or a neurodevelopmental problem, but it's not due to a specific lesion somewhere in the central nervous system. And we're going to emphasize this in the course. My research with others have shown that psychosocial problems are very serious in children with APD. And of course, a very serious consequence of not identifying APD and not doing anything about it is that the child will end up in special education. A lot of resources will be used to try to help them, but they won't be successful because nobody recognizes what their problem is, that it's an auditory problem, and very often they'll do poorly in school to the point where they drop out and sometimes get in trouble with the law. So, and then a final consequence is when you have a child who's not identified early, maybe they're not identified with APD until they're 12, or 13, or 14, you'll never, ever remediate the problem effectively. Whereas if you identify that child when they're 4 or 5 years old or 6 years old, you almost always can remediate successfully. Well, there are also consequences of not identifying APD in adults. And these are serious consequences also. So for those of you who are in clinics where you say, I don't see many children, so maybe this topic isn't all that relevant to me. I would say it is. And the older the adult, the more likely they have APD. Well, same problem. Older adults with APD are not going to communicate efficiently or effectively. It's going to be a lot more difficult. It's going to be tiring. It's going to be very have a great impact on their day-to-day activity, their ability to work, their ability to live independently. Very often, APD is confused or confounded with cognitive deficits. So somebody thinks it's a cognitive problem where really it's an auditory problem, or somebody thinks that there's no sense in dealing with their auditory problem because cognitively they're impaired, when in fact we now know those are comorbidities. And the more you can help the person with hearing, the better their cognition, and vice versa. We also know, well, I just said this basically, that proper treatment for auditory problems will show them either reduce the decline in cognitive function or sometimes actually improve cognitive function. We've also got some recent research that APD in adults, older adults, problems with auditory processing in aging adults, for example, is directly associated with psychosocial problems, just like they are in children. Employment. I've worked with patients who were either going to be fired or they wanted a job and couldn't get a job because they couldn't communicate effectively because of their APD, or people who were really struggling. I bet with everybody from receptionists and people working in fast food restaurants up to high-powered lawyers, all of whom were struggling with employment because of auditory processing problems. Obviously, this reduces quality of life, dramatically reduces quality of life. So, children or adults, for children or adults, there are serious consequences of not identifying and not properly managing APD. All right, I'm going to talk in the next lecture or next week, I should say, week 2, all about coexisting disorders. There are a whole bunch of them. I usually use the term coexisting disorders rather than comorbidity because these are not real sicknesses. These are often just disorders, not diseases. But sometimes people use the word comorbidity. So we'll talk about each and every one of these and also how to evaluate patients with APD when they also have one or more of these coexisting disorders. We're going to also talk about risk factors in week 2, and that's going to be one of the most important parts of the course because for those of you who take option 1, remember option 1 a moment ago, risk factors are how you will know whether or not one of your patients might have APD. So there are clear risk factors in children and there are clear risk factors in adults, and we're going to review all of those in week 2. Okay, now this course is just introducing you to the topic of APD. I'm going to be giving you a really good introduction, but for those of you who want to, you might say, specialize in APD or evaluate patients and also manage them, you're going to want more information. So here's some sources of information. Terry Bellis, who's a big expert on APD, has several books. One of them is shown here. Gail Shermack and Frank Music have actually co-edited 2-volume book. There's in its second edition. I made a mistake here. Frank Music is actually the second author of one edition, the volume 2, but he's the first author in the volume 1. But you can pick these up, by the way, on eBay or Craigslist or go to Amazon and get them quite inexpensive. And although the new edition rather, is definitely got new information, you could actually get by with the first one and still have plenty of very relevant information. Here are just 3 other books that I've come across. The book on the right was by Jack Katz and some of his former students. The one on the left is quite recent. It's been through 3 editions. And these are just simpler books, or not simpler, but shorter books than the big 2-volume book. I've never seen this book in the middle, so I've never read it. Being curious to take a look at it. And then there are books that are actually for parents or for consumers. That is, the person with APD. Terry Bellis has written one of them. It was actually a big seller. People love to read it. And then you've got one by a parent and teacher, one by a parent. The problem with books like this by parents or teachers is that it may not be totally accurate. The information may not be totally accurate because they're not usually scientifically based. And then there are some treatment books. Um, and it's kind of interesting. Teach My Child with ADP. That's the first cover of the first book. That's an embarrassment when they're really talking about APD. So maybe that's intentional. Maybe the person's trying to indicate that somebody's got a phonologic problem, the child does, and they think ADP is APD. But in any event, so these are 3 other options. Actually, there's one on the right, Dorothy Kelly. I've met her, and one time I was at a workshop where I was invited to speak on APD, and she was also. She's a speech pathologist. I remember distinctly that workshop because when we were going out to dinner one night with a group, we're sitting next to each other. I found out that she was born on the same day as me and the same year as me, so we were exactly the same age. But she's coming at auditory processing disorder from a speech pathology perspective, and there's nothing wrong with that. You'll learn in this course that audiologists and speech pathologists work very closely on patients with APD. So by now you probably already had the very first class, but when we get to the national chat, and maybe you've already had that because it's going to be on a Monday of the first week, but if you haven't, or even if you didn't get to it, these are the things that we'll be discussing in the first chat. I want to know more about your experience with APD and whether you took a course in it, where you learned about it, and whether you see patients with the risk factors we've talked about, and how far do you go? What option do you take? Option 1, 2, or 3 in dealing with patients with APD. Now, it's not a textbook for this course, but I did want to point out that I have written an undergraduate textbook. It's quite recent, Introduction to Audiology Today, and includes a lot of information on APD because I knew the textbook would be used by undergraduates, many of whom are going to go into speech pathology, not audiology, and I want to make sure that they had a firm background, pretty much good understanding of auditory processing disorders. So if you haven't gotten a book, you'll find it's a very, very simple, very up-to-date, very clinically oriented overview of the entire field of audiology. Easy reading for a practicing audiologist, but you'll learn something, I guarantee you. So that's the end of lecture 1 in week 1. And the other lecture which you want to listen to this week is the neurobiology lecture.